Welcome to today's Explainer. If you're a surgical resident or just a really focused learner trying to master the nuances of surgical oncology, you're in exactly the right place. Today, we're setting the stage for a high-yield, oral board-style review of colorectal carcinoma. We are stripping away the fluff. We're going to focus purely on the anatomy, the staging, the strict management guidelines, and the precise measurements you absolutely have to know for your surgical boards.
Picture this. You're on morning rounds. Your attending turns to you and says, a patient presents with a T3N1 tumor just 4 centimeters from the anal verge. What is your exact next step? It's one of those high-stakes clinical scenarios that can instantly expose gaps in your knowledge. But don't sweat it. By the time we finish this explainer, you're going to confidently know the exact algorithm to answer this question without missing a single beat.
Okay, let's dive into this. We're taking a strict anatomy to algorithm approach today. We'll hit the foundations of TNM staging, review resection principles and anatomy, break down how to manage colon carcinoma, pivot over to rectal carcinoma, and finally wrap up with surveillance and recurrence.
All right, Section 1, Foundations of TNM Staging. Before we ever pick up a scalpel, we've got to lock down the absolute foundational rules of the disease, which is the AJCC staging criteria. So here's your rapid-fire review of the T and N stages. Look, depth of invasion, that's your T stage, is literally the single most significant predictor of lymph node spread. A T1 lesion just in the submucosa has a way lower risk of nodal metastases than a T3, which breaks right through the muscularis propria into the pericolorectal tissues. And for T4, you absolutely have to know the difference for your exams. T4A breaches the visceral peritoneum, while T4B directly invades adjacent organs. Got it? Okay, for nodal staging, N1 is 1 to 3 nodes, N2 is 4 or more. But here is the golden rule for the OR. You need a minimum of 12 lymph nodes harvested to accurately call a patient N0. Commit that number to memory right now. 12.
Moving right along, Section 2, Resection Principles and Anatomy. Let's shift from staging rules to the physical anatomical foundations of colorectal surgery.
This brilliantly illustrates the foundational principle of our surgery. It's all about the arterial blood supply. You've got the superior mesenteric artery supplying the right and transverse colon, and the inferior mesenteric artery feeding the left and sigmoid colon. Why do we care so much? Because the origin of this arterial supply strictly dictates exactly how much bowel you're resecting. The lymphatics follow the arteries. You can't just pluck out the tumor. You have to take the entire vascular and lymphatic basin that feeds it. And that brings us to a really crucial definition, mesenteric clearance. Basically, a curative resection requires proximal mesenteric vessel ligation and radical clearance of that corresponding lymphatic drainage basin. So, if you're dealing with a right-sided colon cancer, you are ligating the ileocolic, right colic, and right branches of the middle colic vessels right near their origin. You've got to take the blood supply and nodes on block with the primary tumor. For the colon, that means you need at least a 5-centimeter proximal and distal bowel margin to make sure you adequately clear those regional lymphatics along the vessel arcades.
Okay, on to Section 3, Managing Colon Carcinoma. Let's get into the specific management algorithms, starting with early-stage disease in the colon.
Check this out. It's a massive exam high-yield point. We need to consider the levels of invasive carcinoma in both pedunculated and sessile polyps. If you have invasive carcinoma in the head of a pedunculated polyp, assuming no stalk involvement, the risk of metastasis is actually less than 1%. But for a sessile polyp, the flat ones, the depth of invasion into the submucosa completely changes the game.
Let's see how this builds our treatment algorithm for a stage 1 malignant polyp. If you've got a superficial sessile lesion, what we call SM1, an endoscopic resection is usually totally sufficient. But if that invasion reaches deeper into the submucosa, SM2 or SM3, or if you spot high-risk features like lymphovascular invasion, poor histological grade, or a really tight margin of less than 1 millimeter, well, the risk of lymph node spread just skyrockets. At that point, a formal segmental colectomy is absolutely mandated. No way around it.
Now, when formal surgery is required, your options are basically dictated by that primary vessel ligation we talked about earlier. A right hemicolectomy takes the right colon by ligating the ileocolic and right colic arteries. Need to take the transverse colon too? That's an extended right colectomy, where you ligate the middle colic at its base. Tumors at the splenic flexure are a bit tricky. They often require an extended right or a left colectomy depending on whether the dominant blood supply is from the middle or left colic arteries. A standard left colectomy handles descending colon tumors. And of course, if a patient has synchronous cancers or familial field defect, you might be looking at a total or subtotal colectomy.
Post-op, we've got to think about medical oncology. For stage 1, there's no adjuvant chemo. Easy. Stage 2, it's kind of controversial. We usually only consider it for high-risk patients. You definitely need to know these high-risk features for the boards. T4 tumors, presenting with a bowel obstruction or perforation, lymphovascular or paraneural invasion, poorly differentiated histology, or if you had an inadequate lymph node sampling of fewer than 12 nodes. Now for stage 3, meaning node-positive disease, the gold standard recommendation is the full FOX regimen, which is 5-FU and oxaliplatin. But wait, there's a massive exception here. Subsets of patients with MSI-high histology and stage 3 disease actually don't benefit from 5-FU-based therapy. Keep that one in your back pocket. They love to test it.
All right, Section 4, Managing Rectal Carcinoma. We're pivoting down to the rectum now. And listen closely because this is where surgical residents constantly fall into traps during exams.
So the absolutely crucial point here is this major paradigm shift. For colon cancer, as we just saw, we generally do upfront surgery and follow it with adjuvant chemotherapy if the nodes are positive. But for locally advanced rectal cancer, we're talking stages 2 and 3, the absolute standard is neoadjuvant chemoradiation first, followed by a total mesorectal excision, or TME. Why the huge difference just based on the organ's location?
Well, the tight confines of the pelvic anatomy pretty much hold the answer. The rectum lives entirely within the bony pelvis, completely surrounded by the bladder, prostate, vagina, and sacral nerves. Plus, it lacks a serosal covering in the mid and lower portions. Because of all this anatomy, achieving a negative radial or circumferential margin is incredibly difficult. And that justifies the need for super precise preoperative staging to see if that margin is threatened. It's exactly why we use upfront radiation to shrink the tumor down before we ever even think about operating.
Which brings us right back to that hook question from the very beginning of this explainer. You have a patient with a T3N1 tumor, so that's stage 3, 4 centimeters from the anal verge. What's your exact next step? It is not surgery. Step 1 is formal staging with an MRI to specifically evaluate the depth of invasion and the mesorectal fascia for threatened circumferential margins. Step 2 is neoadjuvant chemoradiation. Only then, at step 3, do you actually perform a total mesorectal excision, which is then followed by step 4, adjuvant chemotherapy.
Now, when you do reach step 3 and head to the OR, the distance from the anal verge strictly dictates your procedure. If you can get at least a 2-centimeter distal margin, sometimes we push it down to 1 centimeter for really low tumors, and you can spare the sphincter, you're doing a low anterior resection or LAR. But if the tumor is right on the sphincter, you've got to perform an abdominal perineal resection or APR. That removes the anus entirely and leaves the patient with a permanent colostomy. What about transanal excisions? Those are strictly reserved for highly selected favorable T1 lesions. For the boards, know the exact criteria for these. They have to be less than 3 centimeters in size, involve less than 30% of the circumference, be completely mobile, and sit within 8 centimeters of the anal verge.
Almost there. Section 5, Surveillance and Recurrence. We've successfully treated the patient. Now what happens after the operation?
The whole goal of surveillance is catching treatable recurrences. The standard protocol includes a colonoscopy at 1 year, and if that's clear, every 3 to 5 years after that. We're also tracking serial CEA levels, carcinoembryonic antigen, every 3 to 6 months for the first 2 years to catch any early biochemical recurrence, plus annual CT scans for 5 years. And here is a really fascinating, crucial point. Unlike a lot of other gastrointestinal cancers, if colorectal cancer recurs as isolated metastases in the liver or the lungs, it isn't necessarily a death sentence. Around 20% of isolated liver metastases are potentially resectable for cure, offering a 20 to 40% 5-year survival rate. That's huge.
I want to leave you with a somewhat provocative thought on the shifting paradigm of rectal cancer. With modern, highly effective chemoradiation, we're actually seeing more and more patients achieve a clinical complete response. I mean, the tumor seemingly vanishes before surgery. This has sparked intense debate over a non-operative watch-and-wait approach. Could we one day skip the morbidity of a proctectomy entirely for these patients? It's actively being studied in clinical trials right now. But until then, master the detailed criteria and algorithms we covered today, and you'll be ready for literally any scenario the boards throw at you. Thanks for joining me on this explainer, and keep learning.